doctor that is here. She'll introduce herself. She's here from quite a ways away. And so she's going to cover thyroid for you, and then I am going to take over. We'll take over mini in between, and I'll take over new diabetes and the adrenal drugs, those steroids. My apologies that your exam grades are not finalized yet. I had a wedding over the weekend that was in Connecticut, so I'm about like 48 hours behind my normal schedule, so they should be done tonight. I was watching some in my car right before this lecture, so I have like 3 to 5 to go. And then I'll put all the comments in and release the grades with an announcement, hopefully by today. And I anticipate us ending class of roughly around an hour early. Like I told you guys in the beginning of the semester, you start to get time back. We wouldn't be in here the entire time, so that starts today. So I'm going to guess that we're going to be out of here around 2:50 to 3 p.m. Just so you have an idea. All right, that's great. Thank you.
Hi guys, how are you? So as your instructor mentioned, I'm your guest lecturer. My name is Ms. Johnson, and I am an MSN student for nursing education at the University of Texas, Tyler. And this is my clinical practicum as a nurse educator. I'll be in the lab, and then I'm looking for doing this. So thank you for doing this. And I wanted to be here so badly. I flew across the world to be here with you guys. I live in West Africa right now, and I'm doing my program remotely. So I flew out here for this semester so that I could be with real students instead of reading about them in textbooks. So thank you for being my real student. I'll see if I can really teach you. Let me know if you guys have any questions, if I'm too fast or not clear about something, okay? So before we start thyroid medications, let's do a little pathophysiology review. Thyroid hormones have a profound effect on, select all that apply. Good. So actually, it's kind of a trick question. Thyroid hormones affect every organ in our body and all of our cells. So they have a profound effect on cardiac function, growth and development, and metabolism. So we think about metabolism when we think of people with hypothyroidism having really slow metabolism, right? And we think of cardiac function, and we think of patients with hyperthyroid them having maybe heart failure or tachycardia, high blood pressure, but also growth and development. A big thing is to make sure that our fetuses and small children up to age 3 have enough thyroid hormone because they can have severe mental disabilities and physical growth restrictions if they don't have that thyroid hormone in utero and in early childhood. So here's all the parts of the body that the thyroid hormones affect. You guys learned about the exophthalmos, the bulging eyes. And digestive system, hyperthyroidism is going to have a digestive system that's going really fast. So patient's going to have diarrhea. Hypothyroid, it's going to be slow. They're going to be constipated. Thyroid hormones include, check all that apply. Okay, so this is kind of a trick question because all of these hormones are a good indicator of thyroid functioning, but thyroid actually makes T3 and T4. So T3 is triiodothyronine and T4 is thyroxine. TSH is made in our pituitary gland. We won't worry about TRH today. And so when our thyroid hormones are low in our bodies, our T3 and our T4 are low, our brain tries to stimulate it by increasing the TSH. So whenever you see a high TSH, you know that there's not enough hormone in the body. And the same works the other way around. If there's too much thyroid hormone going to the target cells in our body, and our brain's not going to stimulate it anymore, and our TSH levels will be low in a patient with hyperthyroidism. What we're going for with all of our patients, whether they're hyper or hypo, is going for that euthyroid state, euthyroid. And that's where everything is just in the normal parameters. So that's always our goal. Okay, so we're going to start with hyperthyroidism. Here's the signs and symptoms. You can take notes, you can take a picture. And whenever you're looking for a patient that has too much thyroid hormone in their body, either because we're not effectively treating their hyperthyroidism, or maybe we're over treating their hypothyroidism, these are going to be their symptoms, signs and symptoms. So these patients might not need to eat a lot, but they can get a lot of energy from it. They have high heart rate and high blood pressure. If your heart rate and your blood pressure are up, that's usually when you're angry, or you're scared, or you're sad. So these patients tend to be a little bit jittery and anxious, and they can't help it. Their body's just constantly telling them they're under stress. So they'll be really reactive. Okay, and then we're going to have that bulging neck, the goiter from having a big thyroid. So there's different reasons for having hyperthyroidism. It could be an iodine deficiency, which we don't really have much in the US or even worldwide. There's not a lot of iodine deficiency anymore. There could be a thyroid cancer, or there could be an autoimmune disease called Graves' disease. But either it's either too big, there's too many thyroid cells, or it's putting out too much T3 and T4. So we're going to do this case study. This is what we're going to base everything off of. So let's take a minute to look at that. I can read it to you. The nurse is preparing intake assessment for Jennifer Kale, a 28-year-old biological female. Jennifer came to see her primary care provider because she has concerns about her heart. She states that sometimes she feels fluttering or that her heart is racing. During the assessment, the nurse calculates Jennifer's BMI at 19.6, so it's normal but low. Her skin is clammy, and she has large eyes and rosy cheeks. Her hair is somewhat thin, and she has finger clubbing. She has hyperreflexia and hyperactive bowel sounds. Her vital signs are heart rate 102, BP 140/80, heart rate that's meant to say temperature 98.8, respiratory rate 17, and pain of 0. She reports feeling jittery often, especially in the morning, and has been frequently nauseated and fatigued. When asked, she says that her aunt has Graves' disease. What are some indicators that Jennifer has hyperthyroidism? You can just type in a few things that stand out to you about hyperthyroidism. See what we came up with. Tachycardia, high blood pressure, jitters, exophthalma, good. Goiter, high blood pressure, good. So I think you guys have a good grasp of what hyperthyroidism looks like. So there's 3 treatment options you could do for someone with hyperthyroidism. Destruction of the thyroid tissues, which is radioactive iodine. Leaving the thyroid intact, but suppressing the hormone synthesis, and those are thiamide drugs. And surgically removing the thyroid. So today we're going to talk first about the radioactive iodine. So what's iodine found in? Salt. Yep. So that's kind of it in its natural form. We don't use iodine here too much, but it's used in, It used to be used to clean wounds a lot, but it burns and it stains, but it's a nice cheap option. Um, so let's see. So you may not have seen it much in the hospital, but when patients take it, they'll take a single dose of either a capsule or a solution. And it's radioactive. It's like it's really radioactive. So they're going to be in a very specific room, and the nurse is going to have like very specific handling procedures. And the patient's going to take it, and they're going to take a one-time dose. So you'll hardly ever see it. You may never see it, but you will see it on the NCLEX. You want to know about it, and you want to know how to educate your patients about it. Um, and what it does is because the thyroid attracts iodine, the iodine is absorbed in the thyroid and then it shrinks or destroys the cells that are in there. Do you have any questions about it? Okay, so how would we evaluate the effectiveness? Yeah.
Question about one of the symptoms, like claiming pain. Since the patient would have tachycardia, wouldn't that increase the patient? Why would they have claiming pain?
So if you think about if your metabolism is really high and you're working out, you'll be sweaty. So these patients tend to be a bit sweaty. So yeah, maybe clammy is a weird way to put it because you still associate that with being cold. So they're going to have maybe a higher temperature and be sweaty. And hypothyroidism is going to have a colder temperature and they're going to be really dry. Thank you for that question. Thank you for clarifying that. Yeah. Yeah, so Graves' disease and also hypothyroidism, mixed edema or Hashimoto's, the autoimmune diseases that can contribute to these issues are genetic, partially genetic. Environmental factors and lifestyle factors can affect them, but it is relevant. If someone in your family has Graves' disease, you're a lot more likely to have it. Okay, so we would know that her radioactive iodine is working if those symptoms are going away, right? If she's in the euthyroid state and if her labs are normal, TSH, T3, T4 are all normal, right? Is that how you would evaluate it? Okay, Jennifer's aunt treated her hyperthyroidism with radioactive iodine. This is contraindicated for Jennifer because she's of childbearing age. So since it's radioactive, you don't want to give it to women who might have children. Also, when patients take this, they'll avoid being around small children or pregnant women for a couple weeks. Okay, but if Jennifer were given this, what would we teach her? We're going to look at that. So we're going to look at patient education for radioactive iodine. If Jennifer were prescribed radioactive iodine, what education would the nurse provide? Good. Why do we want her to drink it through a straw so that it doesn't touch her teeth? Yes, because it stains. Do you want to see a nasty picture? So this, when you get cleaned with iodine, this will be on your skin for over a week. So you do not want it on your patient's teeth. Yeah.
Iodine to promote that? Is it because it's a radioactive one?
Yes. Yeah. That's a really good question. Let me do this next question, and then I'm going to answer that because I don't want to give away the answer. If Jennifer were prescribed radioactive iodine, what lifestyle modification teaching would the nurse provide? So she's going to avoid shellfish. Why is she going to avoid shellfish? So what is especially in shellfish? iodine. There's a lot of iodine in shellfish. So if you ever do anything like CT scan with contrast, they always ask, "Are you allergic to shellfish?" Because if you're allergic to shellfish, we can't give you this iodine. So iodine is attracted to the thyroid, and the radioactive iodine works because once it gets stuck there, it starts killing off everything. It's radioactive, right? So that's its whole point, is to destroy cells. So if your patient, or if Jennifer is taking, if she's eating a bunch of shellfish, she's going to have extra iodine in her body. And it's possible that that iodine can dilute the iodine that's radioactive that's going to her thyroid. Maybe the shellfish iodine can be attracted to her thyroid, and then she can eliminate the radioactive stuff. So we want her to have the full benefit of her radioactive iodine by avoiding shellfish for 1 or 2 weeks. You guys have any questions about that one before we move on? Okay, so let's move on to the thiamide drugs. Okay, so there's 2 main thiamide drugs. The point of these drugs is to block synthesis of T3 and T4. They work by blocking that iodine from being incorporated into the ingredients that T3 and T4 are made out of. So then your thyroid can't synthesize those thyroid hormones. So first-line medication, that's what the prescribers will always go to first. And if that's contraindicated, then they go to second line. So methimazole is safer, and a patient only has to take it once a day, but it is less safe for pregnancy and breastfeeding. It's less safe because it more easily crosses into the placenta, and there's a higher concentration of it in breast milk. And why do we not want it to go into the placenta or into the baby's breast milk? Yeah, it will increase toxicity, and it will decrease the baby's thyroid functioning. And then you're going to have that baby with mental disabilities and physical delays. So propylthiouracil, we call PTU, and it's second line because it causes liver damage. And also patients have to take it several times a day, but it is safer during pregnancy. So these medications have some obnoxious side effects that are annoying to patients, but the main side effects that we're going to look for that are life-threatening are bone marrow toxicity. So you guys know what's made in the bone marrow, right? Red blood cells, all blood cells. Yes. So what would be some signs? How would you evaluate your patient for bone marrow toxicity when they came in? You'd see it in their labs, but how would they present? Leukopenia, yes, for the not producing white blood cells. So if a patient had leukopenia and didn't have enough white blood cells, what would that look like for them? That'll be red blood cells. So if white blood cells, they can't fight infection. So what would that look like for someone? Yeah, they're sick. Maybe they have a fever for a few weeks that they just can't get rid of. Maybe they have a sore throat for weeks and weeks and it won't go away. So they come to their provider for that reason. And what about red blood cells? The patient is anemic, has aplastic anemia from the bone marrow toxicity. Shortness of breath, tiredness, yep. Pallor, right? They wouldn't have that good circulation, so they might be a bit pale inside the mouth or on the palms of the hands. Might have headaches. Okay, and what else does the bone marrow make? Platelets. And platelets are for clotting. Good. So what would it look like if a patient didn't have enough platelets? Yeah, they'd be bleeding, they'd have easy bruising, they might bleed when they brush their teeth. I think maybe there's something they're getting gingivitis or something like that. Okay, and how would we evaluate the effectiveness of these thiamide drugs? Yeah, all the symptoms go away. That's how we know it's working. Okay. Can I move on? So the provider recommends a thiamide, a T3, T4 blocker for Jennifer. So what lab result is the nurse least likely to find ordered with that prescription? M7, you guys got it. So why do we want a CBC ordered? Yeah, all those blood cells. We want a baseline of how she's doing. LFT, who knows what LFT is? Liver function tests. Yeah, why do we want to check her liver? Because you might give her something that's hepatotoxic. And if she has decreased liver function, she can't have the PTU, right? And HCG, what's HCG? Pregnancy test. Yes, so we need to know all of those before she can be prescribed these medications, right? Okay. Oh, and also while the patients are getting these medications, they're going to keep getting labs every few months. So they'll keep being monitored. They're some pretty strong drugs. Usually providers don't want them to be on it for longer than 2 years because they're concerned about the long-term effects. So labs are back and they show that Jennifer's CBC and LFT are in the normal range and she's HCG positive. The nurse knows that the provider will likely prescribe PTU or methimazole. PTU, yeah, so she's going to go with the second line drug. Jennifer started on PTU. What adverse effects should the nurse monitor for? Good. So bone marrow toxicity. So tachycardia, heat intolerance, and weight loss, those are all symptoms of hyperthyroidism. So we know that her hyperthyroid drug is not strong enough if she still has those symptoms. That means we need to crank it up a little bit if she has those. Okay, so Jennifer stays on PTU for 2 years. At this time, her provider recommends that she undergo a surgical removal of thyroid tissue, a partial thyroidectomy. So she undergoes her partial thyroidectomy and recovers well. 6 months later, she comes to her provider's office for a follow-up visit. Her intake nurse finds that her vital signs are generally low. Why is this? Hypothyroidism. Yeah, she needs some replacement because she doesn't have enough thyroid cells anymore, right? And so if you see a patient who has a health history of hyperthyroidism and they're taking hypothyroid drugs, see if they had that surgical removal. It's very common. So what might her labs look like if now she's going into this hypothyroid state? I'm sorry? Everything's going to be lower. Her heart rate's going to be low. Her blood pressure is going to be low. Her T3, T4 are going to be low. And what about her TSH? It's going to be high because her brain's saying, come on, get going. Okay, so I like these slides that have all the symptoms. So the tricky one on this, the other one you mentioned, the clammy skin. The tricky one here is the anorexia. So this is not anorexia nervosa, the eating disorder. This means decreased appetite. Maybe the patient has decreased appetite because everything is slowed down. They're constipated. They burn calories really slowly, so they're not that hungry, right? So they're going to have the dry skin, whereas the other patient was sweaty. They're going to be tired, and whereas the other patient was like really jittery and anxious, this one's going to just have this flat affect. It's going to be hard for them to express emotions, and they're just going to have less emotional lability. They'll be less emotionally labile. So we're going to be looking at bradycardia, slower heart rate, lower blood pressure, like someone mentioned. Their temperature is going to be lower. So they're going to be intolerant to cold, and they're going to have that slow, foggy mental functioning. So this is a patient before their hypothyroidism was treated and after. So Jennifer's going to present like this. So what medication do you think she's going to be prescribed? Levothyroxine. So thyroxine is T4. Levo, if you think of elevator or levitate, it raises it up. So it's synthetic T4. So whenever you see it and you get mixed up, like, oh, is it hyper or hypo? It needs to raise that the T4. The nurse instructs Jennifer that levothyroxine should be taken Good. First thing in the morning on an empty stomach. Why does she need to take it on an empty stomach? Yes, for absorption. So you don't want it with her main meal of the day. And you don't want it at bedtime because you want that stomach to be empty. That's just why they say first thing in the morning. It's because that's when your stomach's empty. And you want to take it the same time each day. You'll also teach your patients that they can't even have a cup of coffee with it. They need to take it 30 to 60 minutes before they have anything besides water. So they can have a nice big glass of water and nothing else for 30 to 60 minutes. And we're so careful about this medication being taken at the same time each day that a lot of hospitals will ask the patient when they take it at home, and then they'll put it in the MAR for it to be administered at that time. So all the patients in the hospital could have it at a different time just to keep their own schedule. Other things that you want to teach your patient are that it could take 5 weeks to reach therapeutic levels. So if they're not seeing any results, they shouldn't stop taking it after a couple weeks. They need to keep taking it. Also, they shouldn't switch brands. This is one of those medications where brands really matter. And we can't quite figure out why, because of course, a lot of insurance companies want to pay for like the cheapest one. But for some reason, whether it's filler or whether it's concentration or how it's absorbed, one brand from the next makes a big difference. So if a patient is getting one dose on this brand and they switch brands, they could be getting they could be absorbing a different dose. And how long does it take to reach that therapeutic effect? 5 weeks. So they change brands, and then 5 weeks go later and they're feeling terrible, and they go to the doctor and then he adjusts it, maybe adjust it too little or too much. And 5 weeks later, they're still feeling terrible. So it could take months and months to get them to a euthyroid state. So we're not going to change brands. And you guys should know this information will be so helpful to you because levothyroxine is one of the most prescribed medications. So it's the 4th most prescribed medication in the US right now. So you'll definitely get used to this patient teaching. True or false? Levothyroxine is dosed in milligrams. False. So how many who knows how levothyroxine is dosed? Micrograms. How many micrograms is in 1 milligram? 1,000. So someone my size, I probably get about 75 micrograms in a dose. If I got 75 milligrams, that would be 75,000 micrograms. So I would have a heart attack and die. So it'd be unlikely that pharmacy would fill that prescription, but I have seen pharmacies fill deadly prescriptions where it was an error and an error and an error, and it was the nurse that caught it. And so if you saw a medication that was dosed in milligrams or levothyroxine dosed in milligrams instead of micrograms, what would you do? Yeah, you'd call and you'd clarify because you can't give that to your patient. Always use your voice because you could be the one that saves your patient's life. And if you're afraid to say anything, if something doesn't seem right, and you're like, well, they know what they're doing. I'm just new. I'm just a nursing student. I'm just a new nurse. Your patient could die. All right. So 3 months later, the nurse is reviewing Jennifer's labs, and she finds that her TSH is high and her T3 and T4 are still low. Why is that? Yeah, her dose is too low. It needs to be adjusted. So remember, whenever looking at effectiveness of medications, are they in a hyperthyroid state or are they in a hypothyroid state, right? So let's refresh that a little bit. How would Jennifer present if her levothyroxine dose is too low? Low heart rate, bradycardia, low BP. Good. Good. These are good. The only one that we're going to look at is the hyperthyroidism. So if her dose of thyroid supplement is too low, she'll swing hypothyroid. If her dose is too high, she would get hyperthyroid. And those are the negative side effects of levothyroxine. The negative side effects are hyperthyroidism, basically. If your patient takes too much, then they're going to have that jittery feeling, the fast heart rate. So how long will Jennifer, do you think, need to be on levothyroxine the rest of her life? Why is that? I'm sorry? Yes, because her thyroid was removed. So she's never going to be able to produce enough, even with a partial thyroidectomy. What about all those people that are on levothyroxine that haven't had their thyroid removed? They don't have to be on it for life. Some lifestyle management, diet changes can help. All right. You'll be happy to know that Jennifer's dosage of levothyroxine was adjusted to meet therapeutic levels. She will remain on levothyroxine for life because of her removed thyroid tissue. She takes her medication as directed and lives happily ever after. You guys have any questions? You got it? Good. Let me, before I step down, I told the morning class, I want to encourage you guys that the truth, so I like to encourage people, but only with the truth, is that I kind of ended up at UT Arlington randomly because this is where my family is. So they sent me to this school and I came and I was just blown away by the nursing program. And when you guys get in, I think you're going to love it. You're going to love your instructors. And I'm in the break room with them and I'm like behind closed doors with them. And they're always trying to figure out how they can improve the program, how they can not sweat the small stuff, how they can make sure that you guys are ready to meet national standards, not just the NCLEX, but also to be good nurses. And I was honestly surprised that there's like a program this good compared to when I did nursing school 15 years ago. It's really inspiring. So you guys are on a good journey. Thanks for having me. Oh, thank you. Thank you.
I'm just gonna get my stuff up there, so come back at 1:38 and then I'll go for that.